Endometriosis Foundation of America will be hosting their medical conference on May 2nd through the 3rd in New York City. The topic will be elevating Samson's century legacy via a deep dive with artificial intelligence. To kick off this conversation, we are joined by EndoFound's scientific and medical director, Dr. Dan Martin, to host this special episode of Endo TV. Please welcome Dr. Martin.
Thank you, Diana. It's a pleasure to join you and Endo TV, and a privilege to introduce two giants in endometriosis research and patient care. Dr. Serdar Bulun is a pioneer in the cellular and molecular mechanisms responsible for the development of endometriosis. His lab has uncovered genome-wide epigenetic defects in stromal cells leading to estrogen-driven inflammation and progesterone resistance in endometriosis. Dr. Tamer Seckin is a world-recognized endometriosis surgeon, in addition to being the founder and president of EndoFound, the Endometriosis Foundation of America. EndoFound collects donations to fund more research than any other advocacy group, in addition to running the Empower program for high school systems and providing medical conferences for both patients and providers. Dr. Bulun and Seckin, thank you for being with us today.
Thank you.
Thank you.
My first question is, what is the association of peritoneal involvement of endometriosis with intracavitary endometrium?
I guess I can start answering that question. So endometriosis, when we define it anatomically, right, we define it as the presence of endometrium-like tissue outside of the uterus, including the peritoneal surfaces. And before I answer your question, Dan, I mean, there are a lot of publications that are encouraging the clinical community to change this narrow definition so that it would be more patient-centric, more centered on patients' symptoms, such as adolescent dysmenorrhea that is progressing to chronic pelvic pain. And so endometriosis should be seen as a lifetime disease that is a consequence of repeated episodes of ovulatory menses. And I guess, again, this doesn't happen to every woman who has regulatory menses, and, you know, it happens to 10 to 15%. The $1 million or $1 trillion question has always been, what is it that are that cause the endometriosis syndrome, and also, like, anatomically, the endometriatic lesions in these women? So having said this, I think I've been working on this question for the past 35 years, but I think the most important evidence came from a publication that was published in New England Journal of Medicine, and Dr. Seckin is a co-author. I think it was 2017, is that right, Tamer?
That's right, 2017.
And I mean, I was like, that was a game changer. That was the first time I was sold that, yes, Samson was correct, and everything that we were working towards made sense. What they did was, like, this is a principle that is widely used in all legal systems in the world. In fact, some convicts are exonerated from a life sentence based on this in the real world, and others may get a life sentence. And this is DNA evidence. Dr. Seckin and his colleagues, in a painstaking way, they sequenced DNA of these patients in the intracavitary endometrium, and they mapped these to the endometriatic lesions. And it was not only his group, then another group came from Japan, and another group came from elsewhere, from China, and they all show the same thing. So I don't think, we should at this moment keep questioning, oh, how does endometriosis happen? Does it fall from the sky? I think what we should do is we should just accept this. I know it's difficult to accept by certain groups for various reasons, but accept this and move on, because there are tons of patients suffering from endometriosis.
Thank you. Dr. Seckin, what did Dr. Samson say about peritoneal endometriosis?
Well, Samson was a genius. The guy lived almost 100 years ago. He really defined every element we're still trying to emphasize. He said menstrual tissue outside the uterus, but he also said inflammation. He tried to explain metaplasia. He was a pathologist. He saw these under microscope, and now we are redefining endometriosis, not only condition of glands and stroma, but also inflammation, fibrosis that really causes the patient's symptoms probably. Samson defined peritoneal endometriosis. It's sad our colleagues are basically now attached superficial endometriosis as of origin, as in place of peritoneal endometriosis, original defined by Samson and later. Superficial endometriosis makes the patient's symptoms superficial, less to be believed, or something not important. Yet, these lesions are like the way we see in clinic, patient comes for pain, all right? Pain could be from a single bite of a mosquito or single pimple pain that we know from our skin. It's this peritoneum is a similar thing that covers all of the intestines. Any single lesion is capable of causing pain. And it's like a micro circuit to the brain. Suppose multiple lesions, which people do not believe in causing pain or peritoneum, they call it superficial. This is wrong. I think we should change. Samson said a lot of things, how endometrioma is formed, how deep endometriosis is formed from endometriomas. Actually, deep endo we call today is nothing but 99% of the time from endometriomas that are spilling and causing, basically putting gas on the fire there. I have done so many thousands of endosurgeries. I don't want to say the numbers, which I know, but let's say very few I have seen isolated deep endo without endometrioma, deep endo of the cul-de-sac, just only that without any peritoneal or, it's interesting. So this is a disease of menstruation, and babies come from the uterus, and endometriosis also comes from the uterus. There's no way to deny it. It doesn't come by storks or somewhere else. Let's face the reality and move on. Dr. Bulun has a response to a beautiful article that came out. He was talking about it. He really says endometriosis is not an enigmatic as it often is portrayed in publication. In fact, its physiology, its pathophysiology is more straightforward than many other chronic inflammatory conditions. So really, let's stick to the fact. The science is there. It's not hypothesis anymore. It's a proven theory. It's a fact. It's the truth. It's the reality.
Thank you. Let me go back to what both of you said, and to quote Dr. Samson, he concluded that the intelligent treatment of patients who have peritoneal endometriosis is more important than theory.
What an insightful person. I mean, he said this 100 years ago, right? He's saying, he's not saying let's take these out and cure the patient. He said, let's think about it. How can we approach this patient? Because he understood that repeated episodes of menses was the cause of endometriosis, right? So, I mean, I acknowledge both of you. Without your work, I could have never, without collaborating with you, getting tissues from you, I could have never done what I accomplished. I mean, it's a collaborative process. And the treatment of endometriosis is also a collaborative process between the surgeons and researchers, and also the medical people who use medical treatment of endometriosis. I firmly believe that in quite a few number of these individuals, like in the majority of these individuals, unless we develop strategies to suppress ovulatory menses, I think endometriosis will keep coming back. And so that should also be a strategy. It shouldn't be just like adding Lupron to a patient after a difficult endometriosis surgery, but it should be a lifelong, at least until menopause, a strategy that should be openly discussed with the patient. And here we are going to talk primarily about the chronic pelvic pain aspects of endometriosis, right? I also see tons of patients with infertility. We are developing new methodologies to prepare their utopic endometrium for implantation, because they do have not implantation defects, but also there is an increased risk for miscarriages and things like that. So the endometrium of these patients is clearly not normal. So, so it's a very broad process, and that's how it should be approached.
Thank you. We've discussed inflammation, tissue injury and repair, ovulation, reactions to menstrual tissue. There's some literature, particularly coming from Dr. Khan, on infection as part of all of that. How important does infection seem?
I think the jury is really out on this. I mean, I think let's not. I would caution people who wants to bring infection component to this right now without us, as we are just diving into genetics of this. We will find out. But the infection, you know, endometriosis was classically in the past. Everybody with PID, all endometriosis symptoms were referred as pelvic inflammatory disease. When I was in training years ago in Buffalo, I mean, there was real pioneers there who looked, and everybody was being diagnosed as PID. And then that came gonorrhea, that came put women down, that came chlamydia, and then herpes. Let's not get back to the same route again, in my opinion. There will be RNA involvement probably, but the real cause of endometriosis is defective menstrual tissue that has genetic in certain significant percent, not really least, familial or genetic link there. And like this study that Serdar mentioned, out of 23 of these patients, 17 of them I picked personally from my observation and my surgical series. 17 of them, they had very strong history of endometriosis in the family, and their endometriosis were very aggressive. That's why we found all these mutations very consistently, and they agreed. What makes really endometriosis enigmatic is the first thing that we started. What causes pain? That is the peritoneal endometriosis. There is no blood test or the marker for it. There is no imaging, so it makes it enigmatic. It's the most prevalent component of all three endometriosis the literature mentions. So either you believe in the patient's pain and you look and find the disease, or you never believe. These patients obviously then drift and goes through the cracks of the diagnostic situation. It really makes the endometriosis difficult for people to understand when there's no blood test. So peritoneal endometriosis probably is over 90% of these patients suffer from peritoneal endometriosis. The disease starts from peritoneum. Endometriosis is a peritoneal disease. It starts from there, and it's an intra-abdominal, basically. Very rarely it's extra-abdominal. So our challenge and battlefield is known to us to discover. I would caution people going to the infection path at this stage, but unfortunately, due to the scientific and many other reasons in the industry of molecular science, we will discover and find the truth soon.
I agree that it should be looked at very seriously. I mean, in the beginning, like nobody believed in the H. pylori story for reflux and esophageal or stomach cancer, but it turned out to be very important. So sometimes, and that's an inflammatory condition too. I mean, I think there's very little evidence right now. I agree with cautioning of Tamer, but at the same time, I think it should be looked at very seriously.
And there is also unexplored space and areas that, for example, our classical reasoning will say, yeah, everybody has retrograde menses. Why some get it, some, but we also don't know. And I know clinically, because I perform my laparoscopy during the time of menses within that 1 week of period, people who have endometriosis have significant retrograde bleeding. They flood in blood inside, all right, number one. It's not 1 or 2 drops. They have in volume of blood inside, number one. We don't know the uterine muscle physiology well. We know everything about the uterine muscle physiology in obstetrics. Every contraction is recorded. We have no idea about the electrophysiological function of the uterus. We know inner layer contracts upwards. We don't know we have no idea about the level of cervix, for example, the role of cervix. It's usually these patients have very, very significant cervical component to them. Also, very mild arcuateness that really propels the blood backwards. These are not well studied. We have studied that. We know about 1/5 of the cases, there is very significant finding of subtle degree of arcuateness of the uterus, where centrally the uterus, there's a midline prominence and corneal funneling on each side. And these things are important and needs to be explored, as well as microbiome studies.
Thank you. What I'd like to do is give each of you an opportunity to pick one subject that you think everyone should understand about endometriosis. Dr. Bulun?
I'm going to reiterate the indispensable role of ovulatory menses in the establishment of endometriosis, and I just want to take this opportunity to probably, I mean, others also contributed to this concept, but like Kamran Neshat and, for example, Paolo Vercellini, they demonstrated that repeated episodes into an involuting corpus luteum is the reason why ovarian endometriomas are forming. And I think this is very interesting, and it should be emphasized. And but I think and despite this, we see we don't see an endometrioma in front of our eyes, right? As evidence turning into ovarian cancer, probably because ovarian cancer is so much rarer than endometriosis. Like at any given time, 21,000 women in the US are diagnosed with epithelial ovarian cancer. For endometriosis, I would think that number would be close to 5 to 10 million. So probably, I mean, the numbers are so disparate. That's why we don't see that, in my opinion. But endometriosis is a dangerous disease in that sense, and it may predispose women to other issues, among which are ovarian cancer.
Thank you. And Dr.
I
Seckin?
think my statement on your comment, very, very well said. Ovulation, I mean, we see ovulatory pore in these patients when we also look during laparoscopy. The ovary still has that defect. It's easy to understand how endometrioma can form from that. But I would say endometriosis is one disease. It's not a condition, but one disease. There is one etiology. It's there's unique symptomatology, and there's one treatment. Really, the treatment is removing the disease, whether it is very small or very big, whether it's a cyst or deep. It is excision, removing the disease completely and restoring the anatomy and reconstructing the organs that it is removed, whether it's rectum, whether it is ovary, restoring it to reconstructing to the original anatomy. And endometriosis symptoms is unique. It is pain. That's why I want to call one disease that causes pain in women. So rather than, it's 3 different diseases, 4 different, it is not. There's genetic variances will be happening based on patients' background, on other exposure to other things, which we will discover. But we should really treat as one disease, one treatment, and good treatment that will prevent repeat surgeries. And ovulation suppression, menstrual suppression is a must in patients who are not seeking fertility and to prevent further surgeries. Disease completely needs to be removed by excision with meticulous, inspection of the peritoneum and with fibrosis and inflammation. Not every lesion, I have to say, pigmented. 80% of the time, lesions tend to be subtle, off-pigmented, off-white, and difficult to diagnose at times.
Thank you, Dr. Bulun and Dr. Seckin. It's been a true pleasure to have heard you today. Your knowledge and advancements and progress that we've seen in endometriosis from your care and concern is remarkable. I'd like to turn this back over to Diane Falzone to close the Endo TV episode.
Thank you so much, Dr. Martin. What an insightful and compelling conversation. It is always a joy to have you with us. And make sure to subscribe for Endo TV. And if you're in the New York City area, you can still register for the medical conference. Thank you.